I figured I'd make a little bit of a more fun video for you guys. Today, I just wanted to kind of go into a little bit of like me. I am an EMT. I work in EMS. If you don't know, emergency medical technician. So probably one of the people that'd be coming to you off of an ambulance. There are different levels to the provider care as an EMT. There is EMT, there are your advanced EMTs, there are your paramedics. I'm going to be speaking from the BLS level in perspective wise, in case anybody wants to go into EMS. This is just kind of like a tier list of the type of calls you might get as you go in. If you decide to go into EMS, which you should, it's very fun, it's very rewarding, very demanding, and the pay is not, what it should be, but I digress. This is just something that somebody with experience might tell you. These are my opinions on these calls. This is my opinion. Your experience may vary. There are some times where you might have what could be considered to be an easy issue, but it can be made incredibly difficult simply because you're dealing with difficult people, you're dealing with a difficult environment, you're dealing with annoying family, bystanders or something like that, or somebody did something to make things just exponentially worse. Sorry, I was just checking my camera. It's really bright coming through my stuff there. I hope that doesn't deter anybody. So I'm just kind of wanting to get into the tier list here. So I might be looking at these. I'm going to try to put myself into the basic EMT basic perspective. But I've worked in the field for a long time. And so, these might also dip into like paramedic level type of stuff. But I'll just tell you from my experience what I have seen, what I've worked with, and the types of calls that I have had. Now, some of these, there's actually one or two of these that I have never actually done or seen. So bear with me. All right, so we're gonna get into it. First of all, CPR in progress. I would say we're gonna go time to lock in. If it is no, I'm sorry, I'm gonna put it a little higher up. So a little tricky, and the reason why I explain that is because depending on the quality of the CPR that is being done, they might have a really good chance of living, or they might have just done kind of like not a whole lot for them. Regardless of anything, if you think somebody needs CPR, especially if you're certified or something like that, please go ahead. Go ahead, and especially if you've been CPR certified at some point, go ahead and do it. If somebody's like not got a pulse and is not breathing and all that, there ain't no... Go for it. The heart wants to beat. Anything you can give it will be better. The biggest thing I've ever seen with like a random bystander doing CPR is there's no respirations or rescue breaths ever being done. That's a big thing. Another thing is the pacing of it. You're supposed to do these high quality chest compressions, and I don't always see that being done. If you're ever in doubt, there's a few songs, like the Bee Gees, the ha, 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 staying alive. There you go. It's like boom, boom, boom. Like you can really get nice, good pace with that. Make sure you want to be getting deep. And if they need breaths, for adults, I believe that it is after 30 chest compressions, you want to try and give at least 1 to 2 rescue breaths. For children, that can be more like 15. You want to give them 1 to 2. The biggest thing is to try to keep their heart pumping. Now, due to the fact that it's like somebody random, it's like, I don't want to be touching their mouth or whatever. Sometimes you could take like just a little piece of plastic. A lot of times some people carry masks. So these are like literal masks that you just blow into. to try to protect yourself and add a little bit of barrier precaution, like some PPE. I doubt that somebody's going to just be having one of those on there. I have seen AED kits. Most big public areas are going to have an AED. A lot of gyms will always have one. So if you're near like a Planet Fitness or something, and somebody's like dying, if you can run and grab that, go for it. But a lot of those will actually have, as well with the AED pads, you'll also usually have a mask of some kind. Usually. Let's see. AFIB. AFIB is scary, but I don't think that it's that bad. I would usually, this is going to be something that's a little bit more like a drug managed thing. You're going to be really good with your vitals unless they are like in a full on like blockage of some kind. This is, a lot of these patients will know they have a history of AFib. And a lot of times they will know that they have not had their medication or something of that nature. AFib is a little bit more tricky in my opinion versus something like VFib. Ventricular tachycardia and ventricular fibrillation is difficult, but those are the two shockable things. AFib, you're looking a little bit more, drug managed and things of that nature. So a little bit of it, but not that crazy. Alcohol. I would say alcohol calls, time to lock in. I will explain. A lot of times when you go into an alcohol call, it is a place where it is busy, noisy, clubs, outside of bars and restaurants, or at some college party. And a lot of the times, a lot of those people are already under the influence. But the reason that I actually say that alcohol is tricky is because you want to make sure that you get a blood glucose on these people. Even if you don't really think they're diabetic, because sometimes somebody who is inebriated could actually be just low blood sugar or something like that, depending on their history and who they are. It could be actually a slew of issues, and sometimes getting it out of them it's difficult. So I would say time to lock in. I don't know if that's fair, putting CPR in progress below. Oh, maybe I'm reading this wrong. I thought that it says I can do this in my sleep and never done or call for help. I actually would put... Yeah, I'd put CPR in progress. Okay, so all right, appendicitis. Depends on if it's burst or not already. Appendicitis is nasty and it is difficult and it is not fun to deal with. If you ever have pain in your lower abdomen, please get it checked out. It is a very not fun thing when your appendix bursts. So get some help sooner rather than later when it comes to this sort of thing. I would say it's a little tricky, but if it hasn't burst yet or something like that, you're probably fine. Asthma. I have not had super difficult asthma calls. They are scary and they can be scary, especially when it's like a kid or something like that. But they're actually not too difficult. You just kind of get that albuterol set up and you start giving them that breathing treatment. It's in a lot of places, albuterol is something you don't really need to call, get approval to give. A lot of times you just, boom, give it to them. They can be scary because you do have to coach their breathing because these people are really scared sometimes because, they're not breathing right. Let's see. Systole. Call for help. There is I have very few calls like this. Furthermore, it's very few calls in which I've gotten somebody back like this. One thing that I failed to mention with the earlier, like CPR in progress, is the age of your patient sometimes does determine like what are you going to get out of this. I'm not saying this to be, like pessimistic. By all means, do what you can. We're in a protocol based medical field where we have to do things unless an advance directive exists otherwise. But I would personally say that it is very rare that we get the return of spontaneous circulation on people. It is exceptionally rare in like people that are above like, I don't know, something like 60 or so. If you're above the age of 80, please have a DNR. I do not want to try and crack all of your ribs and have you probably never recover from that. It's just sad for everybody. Which brings me to, I'm actually going to skip over and go to another type of call. I'm wondering if I should do these based upon relevancy. So if somebody's watching this who doesn't have any sort of medical experience, DNR. So this is a big thing. If they have a DNR, boom, I can do this in my sleep. Normally you're going to call for like a supervisor, might have to have like medical examiner or something like that. But somebody has a DNR, and do not resuscitate order, which for our at least my agency's purposes, it needs to be signed, filled out, in date. If there's a single section of it that's not filled out, and I don't know why they do this, but there's always like a segment at the very bottom that says like emergency number to call. It's 911. If that is not filled out, we might not be able to. Anyway, I don't know why they don't ever fill that one out. But with that paper, legal document, it has to be signed by a physician or a PA in the state of North Carolina. If you don't have that, guess what? Your geriatric 70, 80, 90, 100-year-old grandma is about to have my like 190-pound butt on top of them breaking everything. I'm about to sit there and gun their chest until we can get like a Lucas device on them or something like that just to take over compressions for them. And it is nasty. Their stomach gets distended, all the blood pours. It's just nasty. And realistically, even if I was to sit there and get their heart to start back up, and if by some miracle we get a pulse back and they start breathing on their own, it is a brutal recovery process for somebody who is that old. They are more than likely always going to have like cracked ribs for the rest of their life. They're probably going to be bed bound. We've probably crushed like a lot of their organs. Their lungs might even be punctured in some weird cases. It's not a fun case. Anyway, so the DNR order is something that usually a power of attorney or somebody related to the patient says, hey, Mima's getting old. If something happens, we're going to just let her pass. It is, on an ethical level, probably one of the most humane things you can do. So, yeah, have a DNR for your grandma, please. Chest pain. I'm going to say time to lock in. Any kind of chest pain call, you want to treat it with like a very good seriousness, as with anything else. But the reason that I say chest pain is because it could be, I have a little bit of chest pain today only, and it could be just starting to have heart problems, or it could be, yeah, I've been having like an 8 out of 10 chest pain that radiates to my back or my side. And I've had this for the past month and a half. And it's like, brother, you could have had some kind of heart block going on for the last month now. Like, let's get this figured out. These can either go all the way down to I can do this in my sleep to this is the most difficult thing ever. People can decondition real quick. If they are calling EMS, they are hopefully getting to a point where it's like, something's not right and I don't feel like I can drive myself to the hospital right now, or there's significant risk with that. Bee sting. Bee sting, I would say a little tricky. They're bee sting, they're allergic to bees. It depends on how many bee stings are there. Are they allergic? Okay, if it's like one bee sting, if they're allergic, you're gonna manage airway, probably gonna give them some epi, depending on like if they can swallow or not. Maybe start with the Benadryl, epi, some albuterol, whatever. Get that shit opened up, make sure that their airway is good, they're breathing, they got a pulse, and we're avoiding anaphylaxis as much as possible. It's not too hard. It is something that can be resolved. Now, if they are like looking like a swollen, whatever, and they've been bitten like 8 times over, that's when things can get a little difficult. Some people can even like have their own airway occluded because they've swollen up so much. That's when it's really sad. That's why the order of your like allergy medications is going to be important. It's like, okay, if I push epi right now, but were they able to swallow a Benadryl if I give them a Benadryl? And it's like, well, if they can swallow, let's go ahead and give them one of those, so that epi's kind of like, no matter what, I can get some epi in your system. But if your throat starts to swell up and I can't give you Benadryl, it's like, it's just one more thing. You want to get that going as quickly as possible, as soon as possible. Because the other thing is like Benadryl can take like 30 minutes to kick in for some people. So you want to go ahead and get that started if you can. Let's see here. Sunburn. That's a sunburn, or is it just burns in general? Burn. Let me see. Is there another burn somewhere on this list? Okay, I don't see burn, so I'm going to say this is just burns in general. So burns, I would personally say time to lock in. Because depending on like the degree of the burn, how bad it is and how widespread it is, you can have, hey, I burnt my hand on the stove, to 50% of your body is covered right now. Or somebody getting pulled out of a fire. I had a nasty patient one time, who was just like a kid, and he was welding. He was trying to weld a thing, and I mean, his body was like, it was bad. That was one of my worst calls, I think, ever, just graphically. Just because I don't know if he's ever going to like one of the sides of his body he might never really have access to again fully. So burns can be difficult. The other difficult problem is like pain management. Sometimes these people are burnt so bad that like there is no nerves left on their skin. Doesn't mean they're not in pain, but like it's like it's fried, it's crusty, it's gone, right? But they still need treatment and help. But also making sure things are like wrapped up properly. A lot of the times, like a severe burn, we're trying to get them to the hospital fairly quickly. So let's see. Choking. I would say a little tricky, but not like, it depends on how long they've been choking. You can do Heimlich, back thrusts. If it is a child, that is a little bit more tricky. But I have seen people basically pick them up and like you can logistically move them down. Like you're, this sounds bad. Like you're trying to get their lunch money out, what I have seen is if back thrusts, abdominal thrusts don't work, a lot of times I've seen a paramedic go in with like some magicil forceps and try to dislodge it manually with one of those and use like a little like airway camera to kind of try to get that out. And so I've seen that, and I've seen it actually bring somebody back. The good thing about choking, well, I mean, there's nothing good about it, but is that like if it's somebody who's like reasonably young, you know, and they're choking, you get it out, even if they're blue, they can bounce back. Once they start getting some air, they can bounce back pretty good. Now, you want to be concerned about like tissue damage and things of the lack of oxygen to the brain, but I'm saying is that if you can get it out or dislodged, the outlook's pretty good usually. Chemicals, I'm gonna call for help. I'm gonna be honest. I calling my hazmat dudes. I'm calling hazmat specialty fire department. I'm getting glowworm out there because I don't know. Depends on what is the chemical. Can we identify the chemical? Is this a plant that uses a specific type of thing, right? Sometimes we can't even go in until we know. I would say that's a call for some help. CPAP. I think that's a CPAP. Or is that a Venturi mask? CPAP is going to be utilized in a lot of people that need that continuous, like, positive pressure. So basically, like, that is taking over the breathing entirely for them. It's constantly trying to give them a flow of oxygen, so they're not having to use like their lungs. You see there's a lot of like COPD people and things of that nature. I like them. They're not too hard. They have their own like measurement. Depending on the mask, the machine, it might be a little bit more difficult. Like, I might say like PEEP, or like, I think it's, I forgot what the measurement is, like H2O something. I would say that these are a little tricky, but not hard. Good for your asthmatics sometimes. If you can, especially if yours has a connector. Some of them have a thing where you can put albuterol and give them a breathing treatment literally in the system. Is fantastic. It's a great thing. I'm guessing, I don't know if this is like dead on arrival or if this is murder scene. If it is a homicide case, I'm gonna say, I want to say it's an easy call because it is usually an obvious trauma death or something of that nature, but it's also something where it's like, don't really want to touch anything if you can. And typically like a special like medical examiner is going to get called out and look at that. I'm going to call if we're doing this by the ease of it, this is usually pretty easy. A lot of times the most they would want is like getting a lead printed out. If you can do that in a non-invasive way, like if it's somebody, there's like their brains are hanging out and they've been dead for a little while, they ain't doing all that. But like, we want to make sure we're thorough. Like, somebody's been stabbed 10 times. It's like, oh, let's get a lead out on them, because you might have something. I'm going to lead me to my next one. Actually, I'm going to skip through and get this one. Something called PEA, or pulseless electrical activity. I would say these are definitely a difficult call. So you have, okay, that's an easy call because they're probably dead. But if by some miracle, let's say it was like they got stabbed a bunch or something, you get PEA, guess what? You're working it. You're working that. PEA is one of the other scenarios where you might get a pulse back, or you may get ROSC. And it's exciting because depending on the age and what would happen, it's like, hey, if we can get this person back, it's kind of exciting. Like, let's go. You know, like it's fun. But I would say that is going to be the more difficult thing out there. That's going to be one of the more difficult. Once that call is made, hey, guess what, PEA, we're working this. Pulseless electrical activity basically means like your heart might have stopped. Like, you don't have a pulse, but there is still electrical waves going on. Your heart has like a bunch of different electrolytes and chemicals that sends out like a shock, if you will. That can mean, it basically means that your body says, hey, I'll still go if you want me to, but there's like a lot of, usually you'll find that in a lot of like hypovolemic. I mean, there's a lot of different things that could kind of cause a pulseless electric PA situation, but yeah. On that note, let me see if there's anything else related here. Let's just put electrical capture here. I'm gonna put time to lock in. Capturing a lead on somebody to see that is interpreting that is very critical, very important, very, what is this? Can I identify what is going on with them? That is super important. And I'm going to say it's time to lock in, because a wrong reading is very bad. If somebody's having a stroke, I hope that nobody ever misses a stroke, but because with the electrical capture, you can gauge what the next problem is. All right, do we have ventricular fibrillation? I'm gonna hand that off to my paramedic. My paramedic's gonna tell me what to do. We're calling for help. And then supraventricular tachycardia, or VTAC. So you've got VFib, and then we've got VTAC. VTAC is going to probably be both VFib and VTAC are both going to be a shock probably at some point. Just depends on when. Are they going to wait till they get to the hospital to do it? Are they want to do it in the field? There's a few different things that will happen with that. But with these two, this is going to be a kind of a paramedic thing. You're going to have them, they might help, you might throw leads on, but you're not going to be doing a whole lot on that kind of call usually without their instruction. A heart block. I'm also going to say that's a heart block can be very difficult depending on the grade. So it's grade 1, grade 2, and grade 3. Grade 3 heart block could be this person could die, cardiac arrest right now. That's when you're looking at some other types of, like, you're pushing some drugs and adenosine and things of that nature, or atropine or whatever, and it's like that's going to be a little bit more difficult. Let's see. Let's do high blood sugar. High blood sugar is going to be, I'd say, a little tricky. It's not. Actually, no, let's put that on time to lock in. Usually you're going to get these people bolused pretty quickly. High blood sugar it's hard to, like, reverse that as opposed to, like, low blood sugar. Low blood sugar, you're more concerned about getting them aroused in some way. If they're, like, kind of unconscious, checked out their airway. You start with some basic stuff, hit them with glucagon, get a med history if you can, see what all they've got going on. The glucagon will release whatever is left in the muscle into the body. If you can get them into a state, then you're going to hit them with, usually paramedics going to hit them with some D10 or D50, whatever they determine is the best thing, which is dextrose, sugar water. You're going to hit them with that in an IV. And if they, by some miracle, are like, if they're just low and they're just not feeling great, they're a little drowsy, just get them some sugar, some orange juice, or, a little bit of oral glucose. I've had orange juice and put oral glucose in the orange juice and stirred it up, and here's your sugar, right? Had that. So I'm going to say those are actually pretty easy. Let's see, syncope, a syncopal episode. Gonna say time to lock in, and the reason I say that is because usually older people that got up too fast, somebody who's orthostatic and had a fall, and the syncopal episode is big, but falling would be worse, especially for a geriatric or somebody with glass bones and paper skin and all that. Let's see. Is that a STEMI? No. Sorry, I'm not still going through some cardiology. I'm going to put this one as with the heart blocks and the SVT and the VFib. Because, with any type of cardiac emergency, depending on what it is, it's like, you're going to do just about as much as you can. A stroke. I would say a stroke is time to lock in. There's not a lot you can do for them aside from get them there. But the reason I say time to lock in is because you want to do your stroke screen and make sure, determine what the problems are, aphasia, expressive or receptive, weakness. And as you learn more about them, you're going to learn about the different types of strokes. There's a few different types. Early identification is going to help you so much here, because you might say, hey, we think it's a stroke. And worst, if you think it is a stroke, you call it stroke. Depending on how early you catch it, there are different interventions or things you can do for this sort of thing. The earlier you identify it and call it, the better, because you do not want your patient getting to the ER and saying, hey, suspected stroke, or you didn't want to call it a stroke, so they just sit there for 4 hours while they got a blood clot in their brain. Like that would be awful. So you want to identify that, you want to lock in, you want to get that, you want to do all your checks. You're probably going to want to be getting a lead printed out with these people, because that's one of the things that, like, stroke mimics are big, but you can get blood glucose, you're going to get a lead printed out. You might have multiple leads printed out. And then you're going to do your stroke screen, not once, but probably twice. Because you want them to, you don't want the ER sitting there and saying, yeah, we think it's this or that. Send them, their acuity is low. Let me set them. No. Let's see. Dog bites. Hell no. I'm going to be honest. Dog bites are terrifying to me. I have seen, people get, you can see their muscle, you can see their bone, the adipose tissue or whatever it's called, and, just nasty. Stuff's just all out there. Dog bites cannot be too bad, but overall, I'm just like, nope. Of course, we want to ask the question of rabies. That, any bite, I'd say, animal wise, you want to ask some questions about the animal. Were they foaming? And were they oddly aggressive to you? Did they just come out of nowhere? Et cetera, because rabies is even worse. I'm guessing this is a behavioral crisis. This is just a guy he's just this is me every day. So with that, the behavioral crisis is, you don't want to downplay these. I feel like I'm putting everything in time to lock in. You take everything seriously. I have found that behavioral crises are not too bad, a little tricky. If it is somebody that called for themselves on a behavioral emergency, it is a very touching, heartfelt, because usually these people, things got so bad in their brain that they felt like they had to call and treat these patients with absolute dignity and respect. But the times where it's just the shadow people are talking to me and things like that, you still want to treat them with respect and everything, but you have to be very mindful of how you are treating this patient. You don't want to baby them, and you don't want to sit there and lie to them. You don't want to mislead them, but at the same time, you don't want to feed into whatever their paranoia and delusion is. And some of them, especially if it's somebody off their meds, a lot of times they seem to identify anybody medical is the issue. Don't get me on those meds. Don't get me on those meds. Y'all are the bad person. I'd say they're a little tricky. Usually, at least where I'm at, PD is going to be there. You're going to have a police department somewhere, which kind of helps things. Sometimes PD can make things worse, and it depends on the type of officer. I have identified that a lot of the younger officers are better at certain situations than the old head. Sometimes you get an old head out there, and he's just like, he's just gonna make everything worse. No hate. I am fully respectful to my brothers and sisters, but sometimes they do make things a little worse on the in the boo-boo box. Let's take a look here. So, drowning. I have never had a drowning call, believe it or not. Even being in Florida for as long as I was, I did not have an actual drowning call. I would put it, though, in something that was like call for help. A lot of drowning patients, there is a special type of chamber that is required during their recovery process. Like if you pull them out of the water, they drowned, you got pulse back, you did everything like that. You're going to want to make sure that especially if it's cold water, you warm them up, but you don't want to warm them up too quickly. You want to make sure that they have a good gradual increase in their body temperature, not just like instantly. A lot of people are like, oh, let's warm them up. And it's like, yes, but you want to do it slowly if you can. A lot of those patients will need oxygen, but the biggest thing is there is a special type of chamber that exists. I'm not super, I think it's a hyperbaric, if I'm not I cannot remember, so don't quote me on that one. Not every hospital has them. They are a little bit specialized, but somebody drowns and they are able to get a pulse back and stuff like that. It's, I think, required that they stay in one of those things as they like kind of slowly depressurize them, but it's a little rare to see. I think it's an eye injury, blindness. Somebody, these ones are not too, these are a little tricky, usually not too bad. If it's just like you're having to flush their eye out, I've seen some pretty creative things. I remember one time a medic that I was with, he took a water bottle and just punched a hole in it, and then took a nasal cannula, so like what you would deliver your oxygen with, and he just hooked it up to that and sat the cannula like over their eye, and then just flushed the water through. I'm sure there's a better delivery method than that, but I've seen that. I know that in hospitals they have like this contact lens that they'll put on their eye, and then they'll actually just flush like a saline bolus through it. Some people just, so if it is a physical trauma though, that could be a little difficult. Usually you're going to want to cover not one eye, but you actually might want to cover both. And the reason for that is like, if somebody's like, oh yeah, it's just one of my eyes, this eye is overlooking here, there, up, down. And the reflex is that both of your eyes are going to be looking like the same way. So therefore, if one is injured, the other one is looking over here. It might be moving the other eye around and triggering a reflex or some pain, or just making things worse. So you want to make sure that you're actually covering both eyes. You get them to say, hey, I know it's not fun being blind in the back of an ambulance, but I'm going to do this. Sometimes a cup works. Like you just get like a little cup if you can find one. The one that I've had has been like that. Let's take a look. Preeclampsia and eclampsia. I would say difficulty-wise a little tricky. Usually it's not that bad. If you identify it earlier for preeclampsia and eclampsia, this is going to be for your expecting mothers out there. So when the baby is developing, it is really pushing up on a lot of those internal organs inside of mom, and sometimes it presses up against a specific like set of veins and arteries, and it can cause blood pressure concerns. Because quite literally, like, baby's growing and mom's having to make room. for a lot of these patients, you're going to lay them on their left side. Now, when you lay on your left side, the vast majority of people, your liver is oriented a certain way. And what laying on the left side does for a lot of these mothers is it logistically is going to allow blood flow a specific way to try to help them. I believe there are some things that can be done drug-wise to assist with these. They are not on a BLS level. That's normally going to be, I think, something that either the hospital is going to do or your paramedic is going to do. I may be wrong about that. I've only had like one preeclamptic case. Pregnancies are not uncommon. It's just, I would say, rare that you have something insane happen. Biggest thing with your expecting mothers and stuff like that is making sure that they're getting prenatal care and that everything is planned as much as possible, which brings me to pregnancy. I have only had 2 calls. Only one field delivery, and it wasn't even me. That was the medic that I was with. So I would say this is something that you call for help in general. If it is determined that the baby is coming, you've got crowning, it's like this is happening right now. I would say you would ideally want a medic with you, but you know, depending on the presentation of the baby, if it's head first, great. If it's normal, fantastic. If you got a nuchal cord, breech presentation, or, you know, just something's not right, that can be a little concerning. And that is when it's like, hey, Trendelenburg position, let's get to the hospital. But otherwise, it's not, from what I understand, too difficult. Only had 1 field delivery. 1. It is very rare. The only other pregnant person that I have had, we've made it to the hospital. If you get a call for a expecting mother and it's like, this is her 3rd kid, usually after the first one, they kind of come out easier. The mom usually understands the process. The mom is usually familiar with the process, but on top of that, after the first child, it's easier for the mom to deliver after that usually. Let's take a look here. Broken bones. Time to lock in. It is not the most difficult thing. What we've got now, which I really appreciate, is we have nitrous oxide, green whistle, whatever you want to call it now, which is amazing. Kind of helps these patients, like especially if they've broken a leg and they can't walk to the stretcher. Hey, here, you know, little whip it, and they are like woo for like a few minutes, and then you get them on the stretcher, and then you get going. And I think it's a lot of a bet. It can be difficult. You want to make sure you're stabilizing it. You want to check for your pulses, pulse motor sensation, and things of that nature. It's just a lot of pain. Pain management is big with these people, but it's not too difficult. Car wreck. This is one of those ones that's like variable. It's either a little tricky or it's like the worst thing ever, and I don't know where to put it. The vast majority of car wrecks that I have not been too serious. I've had a few very serious ones. I would consider them to be one of those things where it's like, but you always want to treat it as if it's the worst thing ever. When you get there and you finally are able to assist your patient, that's good. The hardest thing with car wrecks I have found is the patients. The patients can be difficult. They are just getting out of a collision. Their adrenaline is usually pumping. But a lot of times they don't understand just how hurt they possibly could be. You want to take a lot of C-spine considerations with these people. If the airbag is deployed, that's a big sign that there was enough force to trigger this electronic delivery in the car. but you want to try to approach from the front because you don't want your patient, looking around and making things worse if they did have, let's say, a cervical injury like that. But it's not just cervical. You want to check all their spine. Cars are getting safer, but they're probably one of the ways that you're probably most likely to die. A car wreck is never to be downplayed, in my opinion. Even if it was like low speed or whatever, the jarring motion, your brain gets shaken, your spinal cord gets shaken. Everything is just not fun about it. But these patients, like, they'll sit there and they'll have like a 50-mile-an-hour wreck, and they'll be on the phone with their mom and the insurance at the same time, already ejected themselves out of the car, and then they'll be bleeding out their face and everything like that. And then you got another person who looks fine, and they're just like, oh, it wasn't my fault. It wasn't my fault, by the way. You're like, buddy, I don't care if it was your fault or not. I am most concerned about you, your health. You're bleeding right now. Come talk. And they're just so worried about the legality of it, the insurance and all this kind of stuff, that it's just like, come on now. When it is a bad wreck, and when it is a person that is really critical, usually, they're usually very compliant. They're usually very desperate for help. That is when you kind of can tell a lot of, take everybody seriously, but when somebody's like, they caused the wreck or something, but they're like, this is everything, please help me, please help me, please help, like that. It's how yeah, this is a situation where something bad has happened, or things could, somebody could decondition really quickly. All right, heat stroke. Heat stroke is, I would say, time to lock in. Heat stroke people are going to get a kind of like symptoms of like neurogenic shock. You want to make sure that you cool them down, but you do it actually progressively. You don't just want to gun them with, I've heard mixed things, but I've heard that the best thing is, and I might get some flack because I don't know if this is correct or not, but I've heard that you want to progressively warm them. So if they were sitting at like 102 degrees for too long or whatever, you don't just want to like blast them with like 50-degree air. You want to progressively get them down in a little bit of a slower pacing. Kind of that may or may not be correct. Hypothermia. So I think that this is also a situation where time to lock in. I have also heard that you want to progressively warm them up, just like with heat stroke. I may not be correct with that. That is the way that I have treated it in the past, and it's the way I've been told to treat it in the past. Hypothermia, I think, is going to be, depends on how bad it is. You want to check like their extremities. Do they have like, are there like digits purple? Is there any sort of frostbite? You're worried about extremity damage with hypothermia, as well as, the cognitive decline. Heat stroke, you don't really worry too much about the outside of their extremities, unless it was like something like they were in a burning building, there was fire. You also want to check them over for like burns and things like that. But with both of those patients, you want to do a good little thorough inspection, make sure that, especially hypothermia, some of these people, like there's a piece of their clothing that like, oh yeah, like, my legs have been cold, and you cut away their pants and it's purple underneath because they had like snow melt, and then it like refreeze their wet pants, and now all of a sudden their like toes are about to fall off because they're so frostbitten. Kidney stones. I'd say a little tricky. There's not a lot that we can do for them. These patients are going to be in an obscene amount of pain, though. They're going to be sitting there like they're going to be a wiggle worm, like they can't get comfortable. I think it's the same with gallstones, but kidney stones, they can't get comfortable. Anywhere they sit, they're just not having a good time. I'd say a little tricky. There's not a whole lot you can do for them. A kidney stone patient, wouldn't say is like, I mean, for pain alone is probably critical, but in terms of a life threat, I think that while bad, it's not going to kill them instantly like some of these other things. Let's see. Lightning strike, never had it. Despite being in one of the most lightning and thunder ridden places in the world, believe it or not, Florida's I think like third or fourth in terms of thunderstorms. Did not get the pleasure of seeing one. I have heard that if you get struck by lightning, you get these like crazy like scars from where like your veins were and where the lightning traveled through your body. Morbid but kind of cool. Let's see here. Needle decompression. Ooh, needle decompression, I would say time to lock in. So a needle decompression is when somebody's had like a collapsed lung of some kind, where their own lung is starting to like suck in and get like a negative pressure situation because somewhere in their chest wall, like something's gone out. Needle decompression, you're literally putting a little needle or like a straw in, and you're going to alleviate that vacuum and get their lung to come back to normal. It is a situation where there's a couple of different areas where you can do a needle decompression. It is absolutely critical that you are getting the right area. If you miss the placement on a needle decompression, you can puncture an artery or a vein somewhere. You can make things infinitely worse. That is a situation where it's time to lock in. Also ALS and paramedic skilling. Some of these are ALS and paramedic skillings. When I say like looking at this as like a basic level, I'm just saying like if you were to just be a normal basic EMT looking at some of these, you're not going to be doing everything, but I'm saying this is the level of difficulty I would call it. I don't know if this is supposed to say a child suicide attempt or just suicide attempt in general. I don't see any other suicide attempt here, so I would say a suicide attempt keyword is going to be something that is time to lock in. Depends on the severity. If it is a massive trauma or they're hemorrhaging a lot, going to want to get them oriented and, stop the bleed, see red, stop red, get them, plug up the holes and go. If it is an overdose or if it is like monoxide or a hanging, there's a lot of different, you want to adjust accordingly. Like for a hanging, you'd probably want to get, a C-collar on them, stabilize them, have them, if they tried to, I don't know what the word is, exsanguinate themselves. You're probably going to want to, of course, stop it, control it, keep that blood in them if you can. If it is a gun, that's going to be a little bit of a tricky, especially if it's in the head region. It's probably where your biggest thing is probably going to be airway management. And then, like for example, they went to like their brain and you just some leads take over their airway. Paramedic is probably going to, at that point, take over and is going to want to intubate them in some capacity. Usually depends on if there's any contraindications. I'm trying to think, like if there was a car or monoxide where they tried to like poison themselves. The problem with monoxide is it goes on, and even if you gave them oxygen, it might not fully reverse that. Those people are normally going to need more demanding treatment. I do not know, but I think that some of them get like a blood transfusion so that they can perfuse properly. I don't know if the offloading of oxygen is blocked entirely by monoxide or not. I know that they need oxygen at some point in their bloodstream. It's just a matter of whether or not their body can process, or their cells can process it. That's probably definitely a paramedic scaling. I have not ever had that before, so I'm not certain specifically with, like, you know, car in the garage monoxide type of thing. Overdoses, time to lock in, and it depends on the kind of overdose. Is it an opioid one? Okay, naloxone, let's go. Get that in them. Might take multiple doses of that. If it is something else, the overdose can be hard to stop and reverse. For example, I do remember an antihistamine overdose one time that I went to, and that was kind of bad. You know, with that, there wasn't really a lot that we can do. There's certain things you can give sometimes to reverse certain drugs. The problem is identifying what did they take. If you cannot identify what did they take, you're going to then move into basic things like keeping them breathing and getting a lead, because if you cannot identify at all what they've taken and nothing is working, the hospital is going to have to try to rush a blood test to identify exactly what drug was it they had. Infant CPR, is that infantile cardiac arrest? Well, this photo is of CPR, which you would be doing a different method depending on, like, you know, the infant size and everything like that. I'm going to assume that this is not just like infantile choking, that this is like an infant CPR. I'm going to put this on difficult. The nature of it being an infant makes it difficult. They are, yes, easier to pick up. They're easier to move. They're easier to shift, but there are a lot of things that are delicate about infants that are not fun. I don't wish this sort of thing upon my worst enemy, and those that do go to these sorts of calls, I do wish nothing but the swiftest and best angel to accompany them. Let's see. Seizures. I'm going to say it's time to lock in. I grew up with a friend or two that had a seizure disorder, and their most common complaint when they were dealing with EMS people was that they were like, oh, it's not a big deal. It's, you know, this and that. You have a seizure, especially if you know, they have one seizure, they're at risk for having more, especially if they have a history of a disorder. Now, what becomes difficult is if these people do not know their history, or they've never had a seizure before. You know, it's one thing if they say, yeah, like, I'm epileptic or something like that. You know, you can kind of get more information and proceed accordingly. The biggest, scariest thing with seizures is if they have multiple. So let's say they have one and they can't stop seizing. Okay, you get them to stop. And they have a second one. Whenever you have a seizure, the electrolytes in the body, like just the entire nervous system in general, is going to go through a lot of its resources. It's going to go through a lot of things. A seizure is not to be downplayed. You also want to make sure that you're taking note of the time that they are seizing. You want to know, like, how bad are the seizures, you know, how long were they for, and how much time was in between if they do stop eventually. You want to make sure you're managing their airway. You want to let these people sometimes have their seizure. You don't want to just sit there and like, hey, stop seizing, you know, like, and a lot of times they're not going to remember things you're telling them. A lot of times they are not with it. Do not expect them to respond properly. Like, I've seen people like, hey, yeah, you had a seizure. Can you tell me more about that? And it's like, you're like, they're just not in it. They're not there, man. But treat these ones with care. GSW, gunshot. I'm going to say time to lock in. It depends on where they got shot, and it depends on like how bad. You want to check for your exit wound. You want to check, see where's the gunshot, how many times were they shot. Can they tell us anything about, do they know anything about the person that shot them, et cetera, et cetera. That's kind of like secondary in my opinion. It's more like a PD thing, but you might want to ask them. You're going to really do a good thorough inspection. This is definitely a situation where you're going to get your shears out. You can go their clothes off, because you need to see that. And you will count entrance and exits. If you don't see an exit, then it's probably likely that it went in, hit something, and started ricocheting around, and that is not fun. It rearranges somebody's guts like that. So I'm going to put those in a time to lock in. Thankfully, the majority of gunshots that I have not been too bad. I had one where this guy was playing Call of Duty and shot himself in his own hand. I don't know, but that one, that was easy. We wrapped it up. He didn't really feel it. It is in your torso, chest, head, neck areas that I would be, and maybe more of your thighs as well, I would be really concerned about. If it is something with like a lower leg or their hands, I would, you still want to proceed with caution because they could bleed out, but I would be a little bit less concerned. Well, it's easier to manage sometimes with that. Tourniquet. So anytime you have like a massive hemorrhage or like an arterial bleed, it calls for a tourniquet. I'd say time to lock in. Those, you're going to put it on them. You're going to warn them. You're going to say, hey, this is about to hurt like a biatch, right? And you do that, and you assure them that this is, like what they need, and make sure that you denote the time in which you do this, because the minute you cut off this blood flow, okay, tissue death can occur, after a certain amount of time. So anything like past a certain point, the rest of the arm or wherever it is going to start not getting blood to it. And the longer that goes on, the more likely it could be that they have to amputate something. I don't wish that upon my worst enemy, but that's what we're going with. All right, and the last one, I have never done a crike. I have never seen a crike be done, and I have never been in a situation where it has had to have been done. It's very rare, but basically a crike is going to be like an emergency trach situation where it is very delicate and sensitive, but your tracheal area, they're going to want to go in and they're going to try to hit a specific tissue, and they are going to give you a third hole to your lungs so that you can respirate. This is usually the case when there is a massive facial trauma. I have never seen them. I would expect this sort of thing to be with like a massive blowout fracture where the airway is compromised both in the mouth but also in the nose. So your NPA and OPA are not going to work, as well as just, trying to intubate them is not going to work. You need to get closer down. So you're bypassing all of this and you're saying, I'm getting right here for my patient to respirate. I had a paramedic one time tell me that I looked like a good person to do a crike on. I wouldn't, you'd have to pay me a lot of money to let somebody do that to me. It's very rare. It is something that can be done. And it doesn't get practiced very much. I'm sure that it is a thing, but don't see it very much. As with anything, like I said before, tried to look at this at like a BLS level. This isn't like at an ALS or like a paramedic level, but this is where I would put the difficulty of these sorts of emergencies in terms of the severity or the emergency nature of them. All of these, in my opinion, everything is critical until proven otherwise. But this is where I'd put the difficulty or how tricky these other things are. So these are my opinions. Feel free to disagree, and feel free to agree with me. I'm sure that some people would be like, behavioral health crisis is the worst thing ever, or I could do an overdose in my sleep. It's all a mixed bag, but also, like I said, you can get to a house and it's, something's supposed to be fairly easy. Like, he's having an asthma attack for the 13th time, and we've got out, and you get there and you're like, okay. And all of a sudden it's families fighting with you, or people are fighting with you. You go to a cardiac arrest, you're trying to do CPR, and somebody is like hovering over you saying, save him, bro. Why aren't you saving him? Save him, bro. And it's like, so these are variable. You can go to an alcohol, potential alcohol poisoning call, and you go and it's somebody's dead, or it's the environment's unsafe. You're in like the most sketch ass area of town. People are fighting you or like trying to grab into your med bag. These are all variable. On my own experience, what I have seen and dealt with, this is where I'd put stuff in general for right now. But thank you for watching. If you like this sort of content, please drop a comment below or subscribe, etc., etc. I don't like to fish for like subscription or bag or whatever, but I am trying to get this ball rolling in terms of this YouTube channel. If you have any feedback, let me know. All right, until next time, peace.